Welcome back to the Deep Dive. I'm glad you're here because today we are tackling a topic that I think a lot of people think they understand, but the reality is just vastly more complex and honestly a little bit terrifying. We're talking about rheumatoid arthritis, or RA. And I'll be honest, before reading this source material, specifically Chapter 4, I fell into that common trap.
Oh, yeah.
I heard arthritis, and my mind immediately went to, my grandfather's creaky knees or that stiffness you get after a long flight, just the inevitable wear and tear.
It is the single most common misconception we face in this field. I think when most people hear arthritis, they're picturing osteoarthritis.
Right.
And that is a mechanical issue. That's the tires going bald, the shock absorbers wearing out, it's cartilage thinning down over decades of use. It's a degenerative process.
Exactly, a mechanical failure. But what we're looking at today, this is not the tires going bald.
Yeah.
This is a situation where the car's internal computer system gets a virus and decides to drive the car into a brick wall.
Repeatedly.
That's a very good analogy. Based on the literature, this isn't your joints getting old. This is your body declaring war on itself.
That is the crucial distinction. We are not talking about a localized injury or simple aging. We're defining RA as a chronic progressive inflammatory disorder. And the phrase from the text that really sets the stage is unknown etiology.
That part always unsettles me. Unknown etiology.
It just means that while we understand the mechanism, the how, we don't fully get the why. We don't know the exact trigger that kicks off the whole cascade.
Okay.
But what we do know is that it's characterized by polyarticular, so multiple joints, and symmetric joint involvement. And surprisingly for many, systemic manifestations. It's not just in the joints.
No.
It's in the blood, the organs, the whole system.
That's the part that really blew my mind reading through this. I mean, we're talking about a disease that involves the body literally creating extra tissue that invades and eats bone. And the treatments range from things like gold salts, which sounds like alchemy to me, to these incredibly sophisticated drugs that target specific molecular handshakes between cells.
It is a story of dysregulation. It's the immune system, which is designed to be our ultimate defense force, turning into our own worst enemy.
Right.
So our mission today is to really unpack the mechanism of this autoimmune civil war, understand exactly how it destroys tissue through something called Panis formation, and then explore the pharmacological arsenal. And it really is an arsenal that we use to try and negotiate a peace treaty.
So let's dive right into the war room. We need to understand the enemy. The source material describes RA as resulting from a dysregulation of both humoral and cell-mediated immunity. Okay, let's unpack that for a minute. We have this internal civil war. How does it actually start?
Well, to understand the malfunction, you have to understand the design. Your immune system is effectively your body's Department of Defense. It has two main branches.
Okay.
You've got humoral immunity, which is sort of like the Air Force or the Navy. It operates through the fluids, the blood, using missiles we call antibodies.
Right, the long-range stuff.
Exactly. Then you have cell-mediated immunity, which is the infantry. These are the T cells that go in and do the hand-to-hand combat.
Okay, so Air Force and infantry. Got it.
In RA, both branches get bad intelligence. It starts with the malfunction in identification. In a healthy body, your immune system spots a foreign invader, a virus or bacteria, and attacks it. In RA, the body begins to produce antibodies against itself.
And the most famous of these is the rheumatoid factor.
Rheumatoid factor, or RF, yes.
I've heard of that. If you have it, you're seropositive, right? But what is it, actually?
This is where it gets really twisted. Rheumatoid factors are antibodies that are designed to attack your own antibodies.
Right.
Specifically, they bind to portions of your own immunoglobulins, like IgM or IgG, so you have your own defense missiles locking onto your other defense missiles.
That's friendly fire on a molecular level.
Precisely. And the text notes a very important correlation here. Patients who produce these rheumatoid factors, the seropositive patients, they tend to have a more aggressive disease course than those who are seronegative.
So it's like their army is more motivated, in a bad way.
In a very bad way, yes.
So you have these autoantibodies. What happens next? I mean, it's not just that they exist. They actually trigger a chain reaction.
Right. So when these antibodies bind together, they form these big clumps, these complexes, and these complexes activate something called the complement system.
Okay.
Think of the complement system as the immune system's amplifier, or a siren. When it gets switched on, it enhances two things: chemotaxis and phagocytosis.
Chemotaxis. That sounds like movement.
It is. It's a chemical signal that basically yells, hey, all troops over here. It's the officer in distress call.
And phagocytosis.
It's just cell eating. It tells the cells that arrive on the scene, these polynuclear leukocytes, to start consuming whatever's there.
And this leads to the release of lymphokines. The text describes this as a presentation to T lymphocytes. This feels like the moment the general is handed the dossier that says, here is the enemy.
That is a perfect analogy. The antigen is processed. It's recognized by these major histocompatibility complex, or MHC, proteins on the lymphocyte surface.
Right.
And this results in the activation of both T cells and B cells. And once those T cells are activated, that's when they start producing the heavy weaponry, cytokines.
These are the bad guys in the context of RA inflammation.
Yeah.
We see these names pop up all the time. But in RA, they seem to be the primary drivers. We're talking about tumor necrosis factor alpha, or TNF-alpha, interleukin-1, IL-1, and IL-6.
These are the pro-inflammatory cytokines. They are the signals that scream, attack, inflame, destroy. They initiate the inflammation, and crucially, they maintain it. They just keep the fire burning. They cause the fever, the swelling, the recruitment of even more destructive cells.
Wow.
But here is where it gets really fascinating, especially with T-cell activation. It's not as simple as just flipping a switch. The text mentions a requirement for co-stimulation.
I love this detail. It really highlights how sophisticated the body is. It's like a fail-safe code for a nuclear launch. You can't just turn one key.
Exactly. The body knows that activating a T-cell is dangerous business. So T-cell activation requires stimulation by the antigen. Yes, that's key number one.
Yeah.
But it also requires a second interaction between cell surface receptors to confirm the order. Specifically, a handshake between a molecule called CD28 on the P cell and CD80 or 86 on the cell that's presenting the antigen.
So if the T cell sees the enemy but doesn't get that handshake,
nothing happens. The nuke stays in the silo. It's a crucial safety mechanism to prevent autoimmunity. But in RAA, the handshake happens. The second key is turned, and the war begins.
And I'm guessing that handshake is going to become a major target for some of these drugs we'll talk about later.
A huge target. If you can stop the handshake, you can stop the war.
So what about the other side of the army, the B cells?
Right, so the activated B cells, they produce plasma cells. And plasma cells are just antibody factories. They churn them out. These antibodies combine with that complement system we mentioned, and this leads to this massive accumulation of those polymorph-nuclear leukocytes. Now, these leukocytes are destructive. They release cytotoxins, oxygen-free radicals, hydroxyl radicals.
Free radicals and cytotoxins.
Yeah.
This is where that collateral damage analogy really hits home for me. These things aren't snipers. They're indiscriminate explosives.
They are scorching the earth. They damage the synovium, the lining of the joint, and the bone itself. They don't care what they hit. It's all just collateral damage.
And we can't overlook the internal signaling. The text highlights a molecule called Janus kinase, or JAK.
Right. This is inside the cell. So think of the cytokines as the person knocking on the door delivering the message. Janus kinase is the telephone line inside the house that relays that message to the nucleus. It's a type of tyrosine kinase, and it's responsible for regulating leukocyte maturation and activation. It basically tells the cell's command center to start printing more inflammatory orders.
So we have the signals, the cytokines, the soldiers, the T cells and B cells, and the internal communication lines, the JK pathways.
Yeah.
But what does this actually do to the joint physically? We mentioned this term pannus in the intro. It sounds like something from a horror movie.
In a way, it is. In a healthy joint, the synovium is this thin, delicate membrane that produces lubricating fluid. It's maybe a few cells thick.
Right.
Chronic inflammation causes this synovial tissue to proliferate. It just grows uncontrollably. It thickens. It becomes vascularized, meaning it starts growing its own blood vessels to feed itself. This thickened, inflamed, tumor-like tissue that is called pannus.
And pannus is invasive. It doesn't just sit there getting puffy.
No, it behaves almost like a malignancy. It invades the cartilage and eventually the bone surface. It releases enzymes that literally digest the bone.
The source text explicitly says it produces erosions of bone and cartilage. So it is eating the joint from the inside out.
That's exactly what's happening, and that leads to the end results we fear. Loss of joint space, bony fusion, where the bones actually fuse together, which is called ankylosing tendon contractures, and then chronic irreversible deformity.
Wow.
This is the physical manifestation of that chemical war. And once the bone is eaten away, you cannot grow it back.
So we know what's happening under the microscope, but what does the patient actually feel? Let's move to the clinical presentation. Because the text mentions something called a prodrome. This isn't just waking up one day with a swollen wrist.
No, and that is a key diagnostic challenge. RA is systemic. So before the joints even swell, there are these nonspecific symptoms.
Like what?
Fatigue, weakness, low-grade fever, anorexia, so a loss of appetite. Patients might just feel off or kind of flu-like for weeks or even months. The inflammation is circulating in the blood before it really settles in the joints.
And stiffness and muscle pain, myalgias, they can happen before the synovitis, the actual joint inflammation even shows up.
Absolutely. But when it does hit the joints, there are some very specific rules that RA tends to follow.
Symmetry.
Symmetry is the hallmark. Unlike osteoarthritis, which might hit your right knee because you favor that leg or played tennis with your right arm, RA usually affects both sides. If the right wrist is swollen, the left wrist is almost certainly swollen too.
And it starts small.
It tends to start in the small joints first, hands, wrists, feet. But it can absolutely migrate to the bigger joints like elbows, shoulders, hips, and knees.
And there's a very specific metric for stiffness. You know, everyone wakes up a little stiff as they get older.
Yeah.
How do you know if it's an RA or just a bad mattress?
It's the time factor. We call it morning stiffness. In osteoarthritis, you wake up, you feel stiff, you walk to the kitchen, make coffee, and by the time the coffee's ready, 10, 15 minutes later, you're loose.
Right, you've worked it out.
You've worked it out. The fluid has moved around. In RA, the stiffness is inflammatory. It typically lasts for more than 30 minutes. In fact, the text says it may persist all day long.
All day. Wow.
It doesn't get better with movements. Sometimes it even gets worse. It's a really profound stiffness.
That is a really clear differentiator. And when you actually touch these joints, what do they feel like?
They feel soft, spongy, warm. They might be red, what we call erythematous. In osteoarthritis, the joints feel hard and bony like knobs. In RA, it feels like a fluid-filled sponge because of that boggy synovitis.
Now, if this goes untreated, we get those deformities we talked about.
Yeah.
The text lists some specific ones that are almost visual signatures of the disease.
Yes. You can get subluxation of the wrists, which is a partial dislocation. And in the hands, you see the classic swan neck deformity and the boutonniere deformity.
And what are those?
They're caused by that pannus destroying the tendons and ligaments that are supposed to hold the finger joints straight. So the fingers get bent into these unnatural positions. You also see ulnar deviation, where the fingers start to drift toward the pinky side of the hand.
It sounds incredibly debilitating mechanically.
Yeah.
I mean, if your tendons aren't pulling in the right line, your hand essentially stops working.
Exactly. You lose grip strength, dexterity, the ability to do buttons or hold a pen. It's devastating to a person's function.
But here is the part that I think surprises people the most. The extra-articular involvement. Arthritis implies joints, but the source material lists this terrifying laundry list of other organs involved.
It is a systemic disease. The inflammation is everywhere. It can cause rheumatoid nodules, which are these hard lumps under the skin, usually on pressure points like elbows.
Okay.
It can cause vasculitis, inflammation of the blood vessels themselves, which can lead to skin ulcers or nerve damage.
And the lungs.
It can attack the lining of the lungs, causing pleural effusions, which is fluid buildup, or it can cause pulmonary fibrosis, actual scarring of the lung tissue itself.
And the heart.
Pericarditis, so inflammation of the sac around the heart, or conduction abnormalities, meaning the electrical signals of the heart get disrupted.
It can even suppress the bone marrow and attack the eyes.
Yes, ocular issues like scleritis are a real risk. This just reinforces why we view RA not as a joint problem, but as a whole body emergency.
Which really reinforces why we need to catch this early. It's not just about saving your grip strength. It's about saving your lungs and your heart. And that leads us to diagnosis. The text mentions a big shift in criteria that happened in 2010. Why the change?
This was a paradigm shift. The American College of Rheumatology, the ACR, and EULAR in Europe, they revised the criteria because the old rules from 1987, well, they relied on late signs.
So you had to wait for the damage to be done.
Pretty much. To get diagnosed under the old rules, you often needed to show bone erosions or those rheumatoid nodules.
But based on what you just said, if you have bone erosions, the damage is already permanent.
Exactly. We were diagnosing the car crash after the car was already totaled. The entire goal of the 2010 criteria was to catch it before the damage occurred. They emphasized the early manifestations.
So how does the new system work?
It's a scoring system. Patients need a score of 6 out of 10 to be diagnosed. But the prerequisite, the entry ticket, if you will, is having synovitis, that clinical swelling, in at least one joint with no other explanation.
And they rely heavily on lab work to build that score. We mentioned the rheumatoid factor, RF, but there's another acronym here, ACPA.
Right. RF is positive in about 60 to 70% of patients, but it's not perfect. It can be positive in other diseases or even just in healthy aging.
Okay.
ACPA, anti-citrullonated protein antibody, is also positive in 50 to 85% of patients, but it is much more specific to RA. If you have a positive ACPA, it is highly likely you have RA. It's a much stronger smoking gun.
They also look at inflammatory markers, ESR and C-reactive protein.
These are basically the body's fire alarms. An elevated ESR or CRP tells us the body is inflamed, but it doesn't tell us exactly where the fire is. But combined with swollen joints and positive antibodies, it builds a very strong case.
And looking at the blood counts, you often see anemia.
Yes, specifically normocytic normochromic anemia. This is called anemia of chronic disease. The body is so busy fighting this internal war, it just stops producing red blood cells as efficiently. You might also see high platelet counts, thrombocytosis, or sometimes low ones.
And if they stick a needle in the joint, which sounds pleasant, and pull out some of that synovial fluid, what does it look like?
Normal joint fluid is clear and viscous, kind of like egg whites. RA fluid is turbid, it's cloudy. It has a very high white blood cell count, leukocytosis, because all those immune cells are flooding the area. And interestingly, it has low glucose relative to what's in the blood.
Why low glucose?
Because those inflammatory cells are hungry, they are metabolically active, and they are consuming the glucose in the fluid to fuel their attack on the joint.
Wow. Okay, so you've got the diagnosis, you've got a score of 6 out of 10. The war is confirmed. Now we have to fight back. Let's talk strategy. What is the ultimate goal here?
The ultimate goal is induced complete remission. We want to shut the war down entirely. If we can't do that, we want low disease activity. The secondary goals are to control pain, maintain daily function so you can live your life, and, crucially, slow those destructive changes.
The text mentions non-pharmacologic therapy first, things like rest, weight reduction, occupational therapy, physical therapy.
Those are all incredibly important supportive measures. Rest reduces the metabolic demand. Weight reduction takes the load off inflamed knees and hips. OT and PT are crucial for preserving range of motion so the joints don't freeze up.
And surgery for severe cases.
Right. Surgery like a appendicitis, removing inflamed tendon sheaths, or full joint replacements can restore function when the damage is too great. But make no mistake, you cannot exercise away a T-cell dysregulation. The primary weapon here is pharmacology.
Let's get to the drugs. Section 5, the first line of defense. The text calls these non-biologic DARDs. But first, you have to explain this concept of bridging therapy.
This is a critical concept. DARD stands for disease-modifying anti-rheumatic drug. These are the drugs that actually stop the war. But they're slow. They can take weeks, sometimes months, to really build up in the system and start working.
So in the meantime, the patient is in agony. Their wrists are on fire right now.
Exactly. So we use a bridge. We use things like NSAIDs, so high-dose ibuprofen or naproxen, or corticosteroids like prednisone to provide rapid relief. They put out the fire temporarily while we wait for the DMARDs to come in and rebuild the fireproofing.
But there is a huge trap here, right?
A huge trap. NSAIDs and steroids make you feel better, but they do not slow the disease progression. If you only take painkillers, that Panlisol will continue to eat your bone even if you don't feel it as much. You must be on a DMARD to save the joint.
Got it. So you need a DMARD, and you need it immediately. And the text identifies one drug as the anchor, methotrexate, MTX.
Methotrexate is the gold standard. It's often chosen first because we have decades of long-term data on it. It works very well for many people, and it's relatively inexpensive.
And how does it work? What's the mechanism?
It acts on multiple levels. It inhibits cytokine production, so it calms down those signals, and it inhibits purine biosynthesis. Purines are building blocks for DNA. By inhibiting them, you stop the rapidly dividing immune cells from proliferating. You're cutting off their supply lines.
But it comes with some serious baggage.
Significant baggage. Because it affects DNA synthesis, it is teratogenic, it causes severe birth defects. You absolutely cannot use it if you are considering pregnancy. It's also contraindicated in liver disease or any kind of immunodeficiency.
And there's a specific supplement you have to take with it.
Folic acid. You must. Methotrexate depletes folate in the body. If you don't replace it, you get some nasty side effects like mouth sores and hair loss. So taking methotrexate requires taking a vitamin to counteract it.
Okay, so if methotrexate is off the table, maybe the patient is planning a family or has a bad liver, what else is in that first-line toolbox? The text lists leflunomide.
Leflunomide is another good option. It inhibits pyrimidine synthesis, a different DNA building block. It has very similar efficacy to methotrexate. A unique thing about it is you can give a loading dose to get it working a bit faster, but again, also teratogenic.
Then there's hydroxychloroquine. This drug has been in the news a lot for other reasons, but in rheumatology, it's a staple.
It is. It's generally used for more mild RA. Its biggest advantage is its safety profile when it comes to the internal organs. It lacks the marrow suppression, the liver toxicity, and the kidney toxicity of the others.
But it has a very specific and kind of scary risk.
The eyes. Retinal toxicity. The drug can deposit in the pigment of the retina. Now, it's rare, but it can lead to blindness if it's not caught. So if you are on this drug, you require regular ophthalmologic monitoring, usually once a year. It's a trade-off. Safer for the liver, riskier for the eyes.
And sulfasalazine.
Another option. It acts as an anti-inflammatory and immunomodulatory agent. It's often limited by its side effects, specifically GI symptoms, nausea, stomach upset. Taking it with food can help, but some people just can't tolerate it.
And the text notes that we often combine these. If one isn't enough, we make a cocktail.
Combination therapy is very common. We might use MTX plus hydroxychloroquine, or what we call triple therapy with methotrexate, sulfasalazine, and hydroxychloroquine all together. We are attacking inflammation from multiple angles to try and get control.
But sometimes even that isn't enough. Or the disease is just too aggressive from the start, what the text calls a poor prognosis. That's when you bring in the heavy artillery, the biologics.
These drugs changed everything. Biologic DMARDs. These aren't just chemical compounds. These are genetically engineered proteins that target very specific parts of the immune system with laser precision.
Before we list them, there's a giant warning label on this entire class of drugs.
Infection. A huge risk of infection. Because you are effectively turning off a targeted part of your immune system, you are removing a key defense. You become more vulnerable to invaders.
So you have to test for tuberculosis before starting. Why TB specifically?
Because your immune system, specifically TNF-alpha, is what keeps latent TB that is sleeping in your lungs from a past exposure in check. If you take a biologic that blocks TNF, you release that check, and the TB can wake up and become active, full-blown tuberculosis.
Wow.
And generally, live vaccines are banned while on these drugs because your suppressed immune system can't handle even a weakened live virus.
Okay, so let's break them down. The biggest group seems to be the TNF-alpha inhibitors.
These target that signal flare cytokine we talked about earlier, TNF-alpha.
Yeah.
By binding directly to TNF or its receptors, they just stop the signal cold. The inflammation order is never received.
The names here are familiar from all the TV commercials. Etanercept, infliximab, adalimumab.
Right. Etanercept is a fusion protein. Adalimumab, which is Humira, is a fully human monoclonal antibody. But I want to highlight infliximab because it's a fascinating story of science.
The text calls it a chimeric antibody. What does that mean?
Chimeric means it is a hybrid. It is part mouse protein, part human protein.
Part mouse.
Yes. The variable region, the part that actually grabs the TNF, is derived from a mouse. The structural part is human. Now, here's the problem. The human immune system is smart. It recognizes mouse as foreign.
So your body might create antibodies against the drug.
Exactly. It fights the drug that is trying to stop the body from fighting itself. We call them human anti-chimeric antibodies. If that happens, the drug just stops working.
So how do you prevent that?
You must take methotrexate along with infliximab. The methotrexate suppresses the immune system just enough to stop it from rejecting the mouse protein.
That is just wild. The complexity of managing that is incredible.
It is. And these drugs carry black box warnings, lymphoproliferative cancers, especially in children and adolescents. And they are contraindicated in congestive heart failure because they can actually worsen cardiac function. They can also cause these strange MS-like neurological symptoms.
So if TNF inhibitors fail, or we can't use them because the patient has heart failure, what is plan B? The non-TNF biologics.
We have some incredible options here that target completely different parts of the war machine. Remember the handshake we talked about? The two keys required for T-cell activation.
The CD28 and CD80. The nuclear launch keys.
Right. Well, we have a drug called abatacept. It's a co-stimulation modulator. It literally binds to CD80086 and caps it. It puts gum in the keyhole.
So the T-cell reaches out for the handshake.
And feels nothing. No handshake, no second signal, no activation. The war is called off before it even starts.
That is such an elegant mechanism.
It really is.
Yeah.
Then there is rituximab. This is a totally different approach. It's a depletion strategy. It's a monoclonal antibody that targets a protein called CD20, which is found on the surface of B cells. It just wipes them out.
It eliminates the antibody factories.
Precisely. It depletes the peripheral B cells.
Yeah.
Then we have tocilizumab, which targets the IL-6 receptor, blocking another one of those angry cytokines. And anakinra, which targets the IL-1 receptor, though the text notes it's less effective and usually reserved for really refractory disease.
And finally, there's this new class. The text separates them from the biologics, the JK inhibitors, specifically tofacitinib. It's called a non-biologic small molecule. Why is the size important here?
It determines how you take it. Biologics are massive proteins. If you swallowed them, your stomach acid would digest them like a steak. That's why they have to be injected or infused directly into the blood.
Right.
Tofacitinib is a small molecule. It's small enough to survive digestion.
So it's a pill.
It is an oral medication, and for a patient, that is a massive lifestyle difference. No more injections.
And what about its mechanism?
It works inside the cell. Remember, JAK is the telephone line to the nucleus. Tofacitinib gets inside and inhibits that pathway. It cuts the phone line. The cytokine might be knocking on the door, but the message never gets delivered to the nucleus.
But, I'm sensing a but, the risks.
Serious ones. Black box warnings for serious infections, lymphomas, and blood clots. It is potent stuff.
So we have this massive arsenal, but managing it sounds like a full-time job. Section 7, managing the side effects. The text really emphasizes monitoring.
It is a delicate balance. We mentioned corticosteroids for flares. A low dose of prednisone under 7.5 milligrams is generally tolerated, but we have to be so careful.
Why? What happens if you stay on steroids too long?
It just destroys the body in other ways. Osteoporosis, so brittle bones, hypertension, hyperglycemia leading to diabetes, weight gain, skin thinning. It's a long, ugly list. We try to use depot injections, injecting directly into the muscle to provide a sort of physiologic taper, letting the drug leave the system slowly rather than keeping the patient on a daily pill.
And the monitoring matrix. I mean, the text has these huge tables, 4.1 and 4.2, just listing what to watch for with each drug.
It's expensive. If you are on NSAIDs, we're watching your kidneys and for GI bleeding.
Yeah.
If you're on methotrexate, we're checking your liver enzymes, your lung function, and your bone marrow every few months.
And the biologics.
With biologics, we are constantly vigilant for infection. Any fever, any cough needs to be evaluated immediately.
It really highlights that treating ORA isn't just take this pill and call me in a year. It's a managed, intense relationship between the patient and the physician.
Absolutely. It requires active participation and communication from both sides.
So let's bring this deep dive home. We've covered a lot of ground. We've covered the Civil War pathophysiology, the friendly fire of the immune system. We've covered the symmetric pain and the all-day stiffness. We've covered the shift to early diagnosis to save the bones. And we've covered this incredible range of drugs from methotrexate to T-cell handshake blockers.
To summarize, I think the big takeaway for you is that RA is not a joint disease. It is a systemic autoimmune failure. The treat-to-target approach means we hit it early and we hit it hard with DMARDs to prevent that PEMS from ever forming and eating into the bone. Because once that erosion happens, we can't undo it.
It brings up a provocative thought for me. You know, we spend so much time in the wellness world talking about boosting our immune system. We take vitamin C, we worry about being immunocompromised. But RA shows us the terrifying power of an immune system that is too strong or maybe just too confused.
It is a humbling reflection. The very mechanisms designed to protect us, the cytokines, the T cells that cause stimulatory handshake, are the exact same mechanisms capable of destroying our own structural integrity. We aren't fighting a foreign invader here. We're fighting our own defense systems.
Right.
So the treatment is effectively a negotiated peace treaty with our own biology. We are trying to suppress the revolt without leaving the castle completely undefended.
A negotiated peace treaty with a chimeric mouse antibody.
Yeah.
I love that image.
Yeah.
And I certainly have a newfound appreciation for my CD28 receptors and the fact that they are hopefully only shaking hands when they're supposed to.
Indeed. It's a marvel when it works correctly.
Thank you for guiding us through this battlefield. And thank you all for listening to this deep dive into rheumatoid arthritis. We'll catch you on the next one. Stay curious.